Oh, thank you. So I'm going to give a brief overview of lupus and then we'll have questions. In academic medicine, we always have to show our disclosures. It means I do research with these companies. And here are our learning objectives. And I wanted to start with how much lupus is there in the United States? It's 200,000. That's why I've circled that number in red. But what you see on the right is the proof, and this comes from the Centers for Disease Control. We all hear so much about them because of COVID, don't we? But they're also quite interested in lupus. And what you see on the right is that lupus is much more common in African Americans and actually American Indians than it is in Caucasians or Hispanics. Now, how do we know that someone has lupus? These are the classification criteria that I published in 2012. And in order to classify someone as having lupus, they need to have 4 things. And at least one of them must be on this list of clinical manifestations. And the first ones that are circled in red are the skin findings that can happen from lupus. The first one, for example, is the one that's sometimes nicknamed the malar rash, which means a rash on the face that occurs after sun exposure. The second one is also called discoid lupus. Oral or nasal ulcers are like canker sores. And non-scarring alopecia means that the hair is very fragile in people with lupus. It breaks off more easily. Now, the next ones are other organ systems. So number 5 means swollen joints. Number 6 means there's fluid in the lung lining or around the heart. Number 7 is kidney involvement. Number 8 are the things that can happen in the brain. And of course, these are quite frightening, things like seizures, psychosis. And the last 3 are different kinds of low blood counts. So remember, to classify as having lupus, the person must have at least one of these. And then they need to have at least one of the laboratory tests. The total still has to count up to 4. And here you see the ANA. Now, the ANA, anti-nuclear antibody, is actually a problem because 20% of normal young women can have a positive ANA. So we never diagnose or classify someone as having lupus based on just an ANA test. Anti-double-stranded DNA is an antibody against the genetic material inside of cells. This next one is another antibody against something inside of our cells. And it's SM, and it stands for Smith. And this is because many decades ago, the doctor in Oklahoma, his name was Mo Reichland, who discovered these antibodies that people with lupus make against normal parts of their cells, named them after the patient in whom he made the discovery. And so now you can guess, right? SM stands for Smith. And I think it's a nice story that, he cared about his patients and he wanted their name, attached to the antibody. But nowadays we live in the era of lawyers. And so with HIPAA regulations, you can no longer name an antibody after the person. Now, the next set of antibodies are called antiphospholipid. And the reason they're very important is, first of all, about half of people with lupus will make one of these antibodies, but they're particularly of concern because they increase the risk of having a blood clot. We call that thrombosis. And they increase the risk of a pregnancy loss, a miscarriage, or even a late intrauterine fetal demise, meaning a very late loss. The next one is called low complement. What is complement? These are proteins in the bloodstream. And if someone has an autoimmune disease, they are used up, they are consumed. And so when they're low, that can be a sign of lupus. And then the last one is an antibody against red blood cells named after the doctor who discovered it. So remember, a total of 4 things. Now I wanted you to see what lupus looks like because a lot of diagnosing lupus early depends on recognition of these things that occur on the physical examination. So here is the photosensitive rash of lupus. It's called the malar rash, but I worry about that because there are many different kinds of rashes on the face. That's what malar means, the cheek region. And most of them have nothing to do with lupus. So just because someone has red cheeks does not mean they have lupus. So what is characteristic, and why have I shown you this photograph? Areas that are shaded from ultraviolet light, and here that would be on the side of the nose, under the lower lip, are spared. Lupus rashes don't occur on the same day as the sun exposure. They occur the following day because it takes time for the immune system to make a reaction. And they're never transient. They last for days to weeks before they fade away and usually require treatment. You can see when you look at this, it looks almost like acne, doesn't it? It looks like they're pustules. But in fact, what you're seeing here is that the skin is raised because this is from inflammation. And inflammation, no matter what it's caused, whether there's a burn or an infection, inflammation causes the tissue to be edematous and raised. Now here's the worst rash. This is the one that's called discoid. This is actually more common in African Americans and more common in people who smoke. And what's dreadful about this lupus rash is that it affects the deeper layers of the skin. So when it heals the same way a third-degree burn would heal. There's permanent loss of the hair follicles. The skin will heal either looking light or dark. The areas here which are still active are the areas that look all crusted. You see that area there and that area there? And I want you to notice how exquisitely sensitive this rash is to ultraviolet light because it's occurring even within this lady's ears, where of course people don't get a lot of ultraviolet light exposure. So what I have to tell my patients who have lupus is just a couple of minutes outside is enough to trigger these rashes. And I advise my patients to always wear a hat with a big brim to cover up. So long sleeves, long pants, cover up the V area of the neck as well. And any area that can't be covered up needs to be protected with SPF 100 sunscreen. Remember, even a couple of minutes in someone with lupus can cause these rashes to flare up. Now, here's an example of the joint involvement. So 80% of people with lupus have skin involvement and 80% or more have joint involvement. You may have heard of another autoimmune disease called rheumatoid arthritis. It turns out rheumatoid arthritis and lupus affect the same joints. The wrists, these are called MCPs, the big knuckles. Small knuckles are called PIPs. And you see here deformities, don't you? I mean, everybody originally noticed when you looked at this slide that the thumb was all bent the wrong way. And this fifth finger is all bent the wrong way. And all the fingers are pointing out to the side. They're supposed to look straight. So how do I know as a rheumatologist that this is somebody with lupus arthritis and not rheumatoid arthritis? I know because if I could reach into this slide, I could straighten these deformities. I could straighten the fingers. I could straighten that thumb joint. Why? Because in lupus, the deformities are not caused by bone changes in the joints. They're caused by the ligament and tendons having been stretched out of shape by past inflammation. And so since ligaments and tendons are soft structures, they're not bony, it's possible to straighten this manually. But in the person's own life, this is really going to affect her hand function because when she goes to pick something up, she can't depend on the end of her thumb. She can't exert the full force with her fingers because they're all pointed in the wrong direction. Now, what I've shown you are the things that are obvious, but there are internal organ manifestations of lupus that won't be obvious to the patient. And one of the most important is kidney involvement. If we look at all people with lupus, 50% will have kidney involvement. But if someone's African American, it's 70%. And it's very important to identify this early through urine and blood tests. Remember, the person won't know it's happening doesn't cause pain or symptoms, because if not treated aggressively, the person can have permanent kidney scarring, leading to the need for dialysis or a kidney transplant. If we look at my patients, so I have about 2,500 people with lupus under our care at the Lupus Center. About 10% have ended up on dialysis or needed a transplant. But if I look at my patients who develop lupus kidney disease in the first year, it's 20%. That's when with the best treatments we currently have. So I knew you would be interested in what causes lupus. And it turns out lupus is one half due to genetics, but it's not a genetic disease. And I mean by that, it's not like sickle cell or cystic fibrosis, where there's a mutation in a gene. And so if the child gets that mutated gene, they've got the disease. That's not like that. This is a genetic predisposition. Now, this slide shows you how doctors study for genetic predispositions. It's called a Manhattan plot. Can you guess why? Because it looks like skyscrapers in New York City. But where you see these big peaks, you see the ones that are labeled, they're much higher than the other buildings. Those are genes that predispose to lupus. But they also predispose, by the way, to other autoimmune disease. It doesn't mean for sure if someone has one of these genes, they're going to get lupus. It just means they're predisposed. What do these genes have in common? They involve pathways in the immune system. So think of it this way. If someone has inherited immune pathways which are overly active, they're probably more likely to make a mistake. And instead of just fighting off infection, which is why we need an immune system, they may accidentally mount an immune response against normal constituents of the cells. And that's what lupus is all about. It's the person's immune system turned onto their own cells. Some people describe it as a disease of friendly fire, to make that military association. Now, if lupus is half a genetic predisposition, it sort of follows, doesn't it, that it's half environmental. We already talked about ultraviolet light as a cause of skin flares, of skin lupus, but it's also just one of the predisposing environmental factors to lupus in general. Many drugs, even supplements, can be the environmental precipitant. I actually worry about echinacea. Have you heard of that one? It's in some over-the-counter cold supplements. It actually activates the immune system and ended up causing kidney lupus flares in about 4 or 5 of my patients before I recognized that it was bad and published that it should be avoided, not just in people with lupus, but in their family members who may have inherited the genetic predisposition. This next one is an antibiotic. You may have heard of it as Bactrim. It's commonly given for bladder infections, but it's also an environmental precipitant of lupus. We already talked about smoking being one of the risk factors for discoid lupus, but it's a risk factor for lupus in general. By the way, for other autoimmune diseases as well, such as rheumatoid arthritis. And then infections play a role. And the infection that's been most tightly associated with lupus turns out to be Epstein-Barr virus, or mononucleosis. Several environmental pollutants have been proven to be risk factors for lupus. Silica, which has contaminated groundwater in many areas. Mercury, of course you know that mercury is even in tuna fish. The only fish that are safe from mercury are actually Alaskan salmon. And then pesticides. And we've polluted our country with pesticides. Now, how do we treat lupus? It turns out that one of the old treatments, prednisone, has actually become a problem rather than a good treatment for lupus. And the reason for this is 15 years after the diagnosis of lupus, 80% of the permanent organ damage is due to prednisone. What does this mean? Well, the most common organ damage that happens to people with lupus are fractures of bone that are due to osteoporosis, and a terrible complication in the hip, knee, and shoulder joints. It's called avascular necrosis, where prednisone actually kills the bone, and the person ends up having to have a joint replacement. But prednisone damages many other organs as well, including, for example, being a major risk factor for cardiovascular events like heart attacks and strokes. But prednisone does help, and it's cheap and it works quickly. It does help rashes, it helps joint involvement. So you can understand it's still necessary sometimes to use it, but we really want to limit it long term so the person doesn't end up paying a price in terms of organ damage. And what our research showed was if we're really going to prevent organ damage from prednisone, the dose has to be less than 6 milligrams a day. If the dose gets above that 6 milligram cut point, the person will have a 50% increase in later organ damage. So this is a message that I've been teaching physicians about, for over 30 years, how important it is that we use other therapies to control lupus so we don't fall back on prednisone. So what are our current treatment approaches, and how and why do we use them? Turns out hydroxychloroquine, which used to be called Plaquenil, is the background therapy that we depend upon. For many, many reasons, it does help skin and joint lupus. It prevents 50% of flare-ups. It can actually reduce organ damage. One way it does this, it can even help to prevent later kidney lupus or later brain lupus. And it helps to prevent cardiovascular events because it reduces bad cholesterol. It can even help to prevent having a blood clot event like a DVT or a stroke because it reduces thrombosis. And it definitely helps kidney lupus. What I've circled in red is perhaps the most important message. It's the only medicine we have for lupus that's been proven to help survival. So I like to call it lupus health insurance. Now, everybody memorized hydroxychloroquine, the pronunciation, even though it's difficult, because you remember that issue way back when COVID started and people were hoping that hydroxychloroquine would help COVID. Turns out it didn't. But it was a dreadful problem for my patients with lupus because it led to a shortage. People were having to ration their hydroxychloroquine. I was having to send people to multiple different pharmacies to be able to find a pharmacy that still had some. The Hopkins pharmacy actually sequestered some just for our patients. Now, most medicines aren't completely safe, so are there any safety issues to having, 200,000 people with lupus on hydroxychloroquine? It's really a very safe medicine. It was actually invented to fight malaria. Millions of people took it for decades for that malaria role. But there is something we need to monitor. Over long periods of time, it can be deposited in the retina, and if that's not detected, it might eventually affect the person's vision. This usually doesn't happen until someone has been on it for 16 years, and even then, it only happens to 1 out of 10 people with lupus. It turns out there's a very easy test called OCT that can be done by an eye specialist. And we ask people to have this done when they first start. And after they've been on it for 5 years, we ask them to do it once a year. And this will immediately tell us if there's any beginning deposition. And how do we know? The very top is a normal retina. You see it has that nice dip? If hydroxychloroquine is being deposited in the eye, the dip is gone. And instead you see this structure in what used to be empty space. And this is actually nicknamed the flying saucer sign. If an eye specialist sees that, they just tell the rheumatologist and the patient that they're going to need to stop their hydroxychloroquine. They'll have no later problems because this is such an early indication that the person has no symptoms or later visual problems. Now, there's another medicine that is very safe that we like to use in lupus, and that's vitamin D. And the reason vitamin D is important is it helps to reduce the protein in the urine that happens if there's kidney inflammation. Now, it turns out there's a tie-in here also to the COVID pandemic because vitamin D is important in preventing viral infections in general and specifically COVID as well. So we want to keep our lupus patients on enough vitamin D so that their blood level stays at 40. But over 50% of people with lupus don't have good control of their disease on medications of hydroxychloroquine and vitamin D. And they're going to need immunosuppression medicines. Now you can guess how these work. They calm down the overly active immune system and therefore help lupus, but they also reduce the normal functions of the immune system. So theoretically, they might increase infection, for example. Right now, we don't have one size fits all. We don't have one that we just universally use. We tie it to the organ system. So for example, if the person has kidney lupus, we use mycophenolate mofetil. If they have joint lupus, we use methotrexate. And particularly if they're planning pregnancy or are pregnant, we use azathioprine, which is the only one which is safe in pregnancy. About 10 years ago, a medication given initially intravenously, and now it can be given as a shot once a week, called bolimumab, Benlysta is the trade name, was FDA approved for people with lupus whose lupus couldn't be managed with our usual medications. And in particular, what we discovered was that it works in a subset of patients who have low complement and anti-DNA. But now I want to introduce to you a very important message, that people with lupus have two types of symptoms. The type 1 symptoms are the ones that are due to inflammation and can be helped by lupus medications. And those are things like the skin rash, the joint swelling, low blood counts, and kidney lupus. But then people with lupus can also suffer from type 2 symptoms, which are not due to inflammation, and therefore they do not respond to lupus medicines. And these are things like chronic fatigue, diffuse pain, cognitive dysfunction, which people sometimes nickname brain fog, insomnia, anxiety, and depression. These are very common in people with lupus. The chronic fatigue and pain often meet the diagnosis term called fibromyalgia. And we do have a way to help these, but we can't cure them. So it turns out chronic fatigue in people with lupus can be helped immensely by a daily exercise program. And the diffuse pain, which is very similar to fibromyalgia, can be helped immensely by Tai Chi stretching and aerobic exercise. But these are very challenging. And in fact, the major long-term complaint of people with lupus is the chronic fatigue. Now, remember that bolimumab was the biologic, meaning intravenous therapy, targeted to an immune pathway. It's been around for 10 years for skin and joint lupus. And it allowed a 20% improvement in people who had this particular immune pathway called the DNA complement pathway. But now it's been approved for kidney lupus, and this just happened last month. This is incredibly good news because we've been depending just on mycophenolate for kidney lupus for over 10 years. And it turns out, on average, only about 30% of people with lupus kidney disease will have a complete kidney response to mycophenolate in a year. So we desperately need to add newer therapies. What was interesting about this lupus kidney disease study was it went on for 2 years. And at 2 years, the people who were on bolimumab on top of their usual therapies had a 10% improvement. Now, I thought this talk was quite timely because yesterday the FDA approved a second new therapy for kidney lupus. This one is called voclosporin. This is a 1 year study, and at 1 year, there's an 18% differential in people with kidney lupus. And also proof, as there was with belimumab, that people respond better when we add this medication than if they're just on mycophenolate. So two welcome, way overdue additions to the armamentarium for kidney lupus. I wanted to talk about long-term complications. It may really wake you up this morning to hear that the major cause of death in people who have lupus is not active lupus. The major cause of death is a cardiovascular event. By the way, I want you to recognize that lupus is the fifth or sixth leading cause of death in young women of color. But remember, it's not the active lupus that's the major culprit, it's the cardiovascular events. Now, why should people with lupus get more cardiovascular events? Well, some of it are what we call typical or traditional cardiovascular risk factors. So more blood pressure, more cholesterol, more smoking, more diabetes. So a lupus specialist spends a lot of his or her time helping our patients get control of traditional risk factors. But in addition, lupus plays its role too. The SLE Disease Activity Index is how we measure active lupus. The lupus anticoagulant was that antibody that caused blood clots. And low C3 is one of the immune pathways that occur in lupus. So the person with lupus, we want to control these things too. And remember, blood clots, thrombosis, such a problem. We now have a handle on that. We know also that's the low C3 immune pathway. And this is the RVVT test is how we measure lupus anticoagulant, that antiphospholipid antibody. So we're getting better. We now have a handle on what we need to do to prevent some of these long-term complications. But there's so much to do. And I know one of the questions that you had was, what about COVID and lupus? We want people with lupus to get the COVID vaccine because people with lupus have a particular problem with multiple viral infections, not just COVID, but more problems with things like influenza, more problem with infections like pneumonia. But there's so many things that go wrong in a person with lupus. Active lupus, more infections, more heart disease, more kidney failure, more cancer, things we didn't have time to talk about this morning. So I often think about this painting of Saint Sebastian, all those arrows. I have to keep track of all those arrows. I have to treat the total person. I have to be a partner, right? Now that's something important for physicians, shared decision making, because there's so many things that could go wrong. There's so much education that is important. So I wanted to thank you for your time this morning. And now we're going to open it up so there can be a little bit of time for questions.
Wow. Thank you, Dr. Petri. That was an amazing presentation. I felt like um, I was in medical school. I'm sure
Well,
our audience
but science is everywhere now, isn't it?
it is
Imagine how much science we've all had to learn because of COVID.
just
I
in the
mean,
last few
everybody
months.
knows what an mRNA vaccine is. I didn't know what an mRNA vaccine was before COVID.
So we've got quite a few questions for you. Some people at registration sent their questions in for you in advance. And then since we've been live, there have been some questions that have come in through comments on Facebook. And so we can start with one. And Janine, please jump in with other questions because I know you have the list as well. One question: do you have advice for those trying to get pregnant with lupus or lupus during pregnancy? And I know this is one of your research areas.
So, yes, back when I came to Hopkins 35 years ago, patients with lupus were being told not to get pregnant. But I had trained in San Francisco where our patients did become pregnant and most of the pregnancies were successful. So I sort of changed everything. What is the rule? The lupus needs to be under good control before the lady conceives because it's active lupus that leads to problems of miscarriage and very preterm birth. So that means we just have to get the medicines lined up so that they're safe in pregnancy and we make sure that the lupus is under good control. That means that the great majority of women with lupus will be able to have a successful pregnancy. They need to be seen more often because kidney lupus is the one organ that likes to get worse during pregnancy.
Okay. Another question that came in on Facebook: do you talk to your patients about lifestyle modifications? For example, managing stress, physical activity, and other things.
So, yes, there's definitely a lifestyle or holistic approach that's very important for lupus. Now, you remember the ultraviolet light part that we talked about. You must cover up. You must use your sunscreen. You must have a hat with a brim, right? So that's a lifestyle change. But luckily, hats are still in fashion, and you can find one that looks nice. But then there are the type 2 symptoms. You remember those? Oh, those require lifestyle change. I know that people want to have a pill, right? There isn't a pill, it's a lifestyle change. So, the holistic approach to chronic fatigue has actually been proven by scientific studies. There are two clinical trials now that show that 80% of people with lupus and chronic fatigue will improve with exercise. But, that's a lifestyle change. Not always easy to find the time to do that. And the chronic pain that's so much a part of fibromyalgia, doing the Tai Chi for arthritis tape every day can lead to a 50% reduction. But oh, there are other lifestyle changes. People with lupus have an increased risk of cardiovascular events, so they need to be heart healthy. That's a dietary change, isn't it? Low fat, reduction in calories, keeping your weight ideal. So, yes, lupus requires a huge amount of education, lifestyle change, and partnership because I think everybody with lupus is going to do better if they can partner with friends and family, right? It's more fun to walk with somebody else than it is to walk all by yourself.
That's thank you for that, Dr. Petri. Another question that sort of falls into the continuum in terms of of age of when patients have been diagnosed. What is the earliest that you've seen a patient diagnosed with lupus?
So it turns out lupus can occur in children. And in children, it's particularly difficult because it nearly always involves kidney lupus. So it's usually children who are around puberty, but yes, I've had patients as young as 6 with lupus, and I do take care of pediatric lupus as well.
Oh,
But the great majority of people will have their onset in their 20s or 30s. There are rare exceptions. I have had patients with onset in their 70s, but think of it as a disease usually of young adults, and it is much more common in women than in men. It's 9 women for every 1 man.
We've got a couple more questions because I know we have to keep moving. There's so many questions here. Um, are there certain foods that might cause a flare up?
So we know a little bit. We never know enough about food, do we? Because there hasn't been enough nutrition research. So we do know there are a few foods that people with lupus should avoid. One of them is alfalfa sprouts. That's from monkey research. I don't know anybody who eats just alfalfa sprouts, but when monkeys did, there was a compound in the alfalfa sprouts that caused lupus. And then we do ask people not to be garlic lovers because garlic activates the immune system. And remember, the immune system is already overly active in lupus, trying to attack parts of person's cells. So really limit garlic. But in terms of an anti-inflammatory diet, oh, the research there is just not, up to snuff. It's not ready for prime time. So that's one of the areas where a lot of attention really should be addressed.
Okay. One other question. You talked about how lupus has a greater impact or is more often found in African American women and women in general. So is there something specific about or particular about women or African American genetics, or are there hormones that are women's hormones that are more receptive or related to lupus?
So first, why women? The Nurses' Health Study proved that women who were exposed to estrogen and oral contraceptive pills or hormone replacement therapy after menopause were more likely to get lupus. So there is a hormone tie-in. Why African Americans? And now those new data, why American Indians? That's genetics. So the genetics can help lead to new therapies because the genetics are telling us that certain immune pathways are involved. So I'm actually hopeful that work on the genetics of lupus is going to find new ways of controlling and, of course, someday curing lupus.
Okay, great. Janine, any other questions before we move to the next one?
No, because I like to say, Dr. Petri, your presentation was, it just hit on every point, the when, the where, the how, the treatments. So not at this time, but I'm certain that there will be more as we move forward. So thank you.
Thank you all. Bye-bye.
Okay. Thank you again, Dr. Petri. So as I stated in the opening, we may not be having this discussion today had our next presenter not brought her story to